Health Department, providing a brief update of the activity in DuPage County. Thank you, Dr. Chug.
Great, thank you, everyone. And excuse me, I did get a sneak peek of Dr. Pinsky's slides, so I think everyone's in for a real treat of information. So I'll try to be brief, and I appreciate the accommodation since I need to sign off shortly. But yes, just really want to focus. So yeah, my name is Rashmi Chug, pronouns she, her, hers, and I serve as medical officer at the DuPage County Health Department. And talking today about our local experience reflected in our data, or our data reflecting the individual experience of our DuPage County residents and community members who have had monkeypox or close contact with someone with monkeypox. And so really talking about the landscape with our local activity and again, the impact of monkeypox. Next slide, please. So wanted to start with really applauding our partners here with HEART, Health Equity and Access Response Team, moving beyond COVID-19. Of course, many of we're still in the midst of our pandemic, but acknowledging that here we have monkeypox and so many other challenges pre-pandemic and going forward. So this is an excerpt from the CDC's technical report number 2, multinational monkeypox outbreak. And this just came out last week. And it outlines a list of priority research topics, gaps and potential areas of focus for future or even current study has begun already in some of these areas. And the area I thought that really resonated would resonate with this group is health equity and stigma reduction during public health emergency. And that first bullet point is really a global, national, statewide, and local priority. But the second one I thought is really something that we are already aligned with and maybe even a little ahead of, but can help guide our efforts and kind of, help us maintain focus. And that's to evaluate the equitable distribution of testing, treatment, prevention measures, and other resources, and evaluate measures to improve access for underserved groups. So that really, again, aligns nicely with our HEART efforts. Next slide, please. So here we have an epi curve or a histogram that really shows our activity in DuPage County since 3 months ago, since early June. So we had our initial case reported in June, and then a lot of testing was happening. And as you may recall, testing was initially very limited and restricted through Illinois Department of Public Health lab approval or Illinois Department of Public Health approval, and it was only performed at their lab or labs facilitated through public health. But since then, fortunately, since early July, actually, testing has expanded to multiple commercial labs. And so prior approval through the health department is no longer needed. And then since then, testing has expanded and as well as activity. So we received quite a number of reports in July, and then it was a little quiet. And then another small wave of cases there in August. And our most recent case was tested on August, had a positive result on August 24th. Next slide, please. I will mention, sorry, Chris, if we could go back to that previous slide, that this really matches what we're learning of statewide and national reports of monkeypox activity. In fact, it was just earlier today, Dr. Connie Austin of the Illinois Department of Public Health was providing an update and mentioned that about 3 weeks ago, Illinois Department of Public Health was receiving 20 to 40 case reports per day, and now they're down to 2 to 10 per day. So that's encouraging, but there are still a lot of uncertainties and unknowns. So and all the more important for us to be having this forum here for improved messaging on how to contain and prevent spread. Next slide, please. Thank you, Chris. So our local data here shows that as of yesterday, and I know this is current as of today, we have 19 cases reported, 10 confirmed and 9 probable, which are they all meet criteria as cases. All are male adults with an average age of 30 30 years, ranging from age 18 to 48 years. When we break down our cases by race and ethnicity, we are seeing a disproportionate impact in our minority populations, with over a third being of minority races, and again, over a third, 36.8%, being of Hispanic or Latino ethnicity. And then also of concern is that 4 of our cases are co-infected with HIV. And then another concern in these data is that over half, you'll see 52.6% have unknown status. And I'll reference this later in the slides about HIV testing and other relevant STD testing. Next slide, please. So moving on through our data, again, 19 cases. And when we look at of our cases, who has warranted, we've been assessing as part of it's part of the case investigation to assess if the individual or through their provider and through the individual, if they meet criteria for treatment, which is tecovirimat or TPOXX. And you'll learn more about this through Dr. Pinsky's presentation, but we've had 3 of our cases, 3 of the 19 meet criteria and receive treatment. And anecdotally, we're hearing that it's quite impactful, that within 2 or 3 days, they begin experiencing relief. And we are also able to break these data down by race and ethnicity. And thankfully, so far, similar to what we're hearing at the state level, that these that the proportion of cases treated does appear to be equitable and matches the proportions by race ethnicity in our cases. So for example, in our 3 cases that were treated, it's a small sample size, but at least even with this small sample size, we're seeing that 2 of the 3 are of minority races, and 1 of our 3, so a third are Hispanic or Latino. And then of concern from a severity perspective is that 1 of our cases did need to be hospitalized, but thankfully has since recovered and been discharged to home. Next slide, please. And so we're talking about cases who were exposed through either one known or multiple known settings. And this is just a breakdown of what we've learned through our case investigations from those individuals, sharing their recent history of travel, domestic as well as international, and especially our earlier cases who may have had intimate contact, direct or intimate contact with MSM is the abbreviation for men who have sex with men, or basically representing gay, bisexual, or same gender loving men. And so we have a combination of domestic, international, and then some of them reporting intimate contact in those settings or during their travel, and then also locally, persons who attended large gatherings, either pride related or non-pride related. Some reported only intimate contact, and then others one reported only heterosexual contact and visiting a gym, and another reported no exposures other than working at a gas station. And both of those individuals did report direct contact. With one was through athletic or sports activities, and another was direct hand-to-hand contact with a customer. And then again, we've had some individuals who have either not responded to our multiple attempts of outreach or have not provided information related to those questions. Next slide, please. So we see kind of a ripple effect as with other communicable diseases. We have our cases, and then the individuals were humans, and we have, contact with our family and partners and community. So this tracks the contact investigation portion of our surveillance. And so we've to date had 55 DuPage County resident contacts identified, and with varying degree of exposure risk. Of greatest concern are those with high or intermediate risk of exposure, and they're the ones who have had either direct contact or prolonged exposure. And those that are in that high or intermediate category have been offered to receive post-exposure prophylaxis, that's PEP, or the Jynneos vaccination, which you'll hear about also through Dr. Pinsky in a little bit more detail. And so 15 residents who were identified as higher intermediate risk contacts have received or begun receiving the 2-dose series of Jynneos vaccination. There have also been 54 healthcare facility exposures. So that means of our cases or individuals who live in other jurisdictions who had their healthcare visits in DuPage County, there have been 54 healthcare facility exposures needing follow-up in DuPage County across 22 facilities. So that could reflect a hospital emergency department or an immediate care and urgent care center, or in at least 1 or 2 situations, it was a primary care physician's office. So across the spectrum, and then, or certainly inpatient, since we've had the one hospitalization as well. So through those exposures, we've had 86 associated healthcare worker contacts in DuPage County facilities, regardless of where they live, since we work with those facilities to help symptom monitor and offer eligible persons post-exposure prophylaxis. So the monitoring period is ongoing for 8 of those individuals. And then some have received post-exposure prophylaxis as well. Next slide, please. So as I mentioned, we have over 50% of our cases who have an unknown status of HIV infection. And really, this is an opportunity for at-risk individuals to be evaluated as comprehensively as possible based on exposure risks. So this is a slide or content from the link there is at the bottom, but from CDC guidance for recommended STI or sexually transmitted infection testing in sexually active gay and bisexual men. And that testing, in addition to monkeypox evaluation, if they haven't been recently tested, should include HIV, syphilis, hepatitis B, hepatitis C, based on specific risk factors, as well as chlamydia, gonorrhea, and sometimes a herpes test may be recommended. And then that may be in the context of other diagnoses, such as varicella or chickenpox, or shingles, or hand, foot, mouth disease, and other possible conditions. Next slide, please. So I'll conclude here just with some links to our local, state, and national CDC level resources. And with that, I will conclude and be happy to address any questions either now or if you could forward them, then myself or Mila or Chris from the health department would be happy to help address them. Thank you so much.
Thank you, Dr. Cho. It's very important work that you guys are doing, and it's great to hear those statistics and to hear that the case numbers are downward trending. That's exactly where we want to be. Dr. Pinsky, are you ready to start?
Okay, I was just trying to unmute myself. I am ready. Okay. And how's my audio? Is everything good on your end?
Sound great.
Okay, great. So I have a challenge here because I was told not to rush this. And I do have a lot of slides, so I'll try to move quickly, but speak slowly if that's possible. All right. So let's go to the next slide. So, what is monkeypox? Monkeypox is a virus. It's a member of the pox family. And specifically, it's a member of the orthopox genus. And other viruses in the orthopox genus include smallpox, also called variola, cowpox, vaccinia virus, which is the smallpox vaccine, and other viruses. Other pox viruses you may be aware of are molluscum contagiosum, parapox virus, and some others. So what is the history of monkeypox? Monkeypox was actually originally discovered first in 1958 when there were 2 outbreaks of a pox-like disease that occurred in colonies of monkeys that were kept for research. The source of the disease is still unknown, but there is an animal reservoir in African rodents. And it is felt that African rodents and non-human primates might harbor the virus and then infect people. The first human case of monkeypox was reported in 1970. And one other fact, there are 2 clades of monkeypox, the West African clade and the Congo Basin clade. The West African clade is the less severe, and that is the variant that is circulating now in this current outbreak. Now, there were sporadic cases of monkeypox in some African countries prior to 2017. In the United States, there was a large outbreak of monkeypox in 2003 that was linked to prairie dogs that were sold as pets. Subsequently, there was an outbreak in Nigeria in 2017. Since 2017, there have been isolated cases in the United States that were from travelers in from Nigeria or other African countries, or their secondary contacts. So a little bit more about the outbreak of 2003. We were very involved with this because we had cases locally at some of our local hospitals here, and I saw some of these patients. There were 47 cases ultimately that were linked to the prairie dogs sold as pets. The story is there was a shipment of 800 small animals from Ghana that actually introduced monkeypox virus into the United States. Researchers learned that there were 2 African giant pouch rats, 9 dormice, and 3 rope squirrels in the shipment that were tested positive for monkeypox. And what they learned after the investigation was after the importation, some of the infected animals were housed near prairie dogs at facilities of an Illinois animal vendor. And so these prairie dogs were sold as pets, and then they were then human cases. Now, in the investigations, all the human cases had contacts with infected prairie dogs, and there were no cases that were attributed exclusively from person-to-person contact. The outbreak was ultimately contained through elimination of the prairie dog population, an embargo of prairie dogs sold as pets, as well as restriction of importation from Africa. So since 2003, we really not have seen monkeypox until now. So how about Nigeria? So in Nigeria, there was a resurgence in 2017. And this was associated with a fall in population immunity to smallpox. In 1970, 70% of the population was immunized against smallpox. This fell to 10% in 2016 because people were getting older and people were not getting vaccinated as children anymore. And so the combination of waning immunity, decreased population immunity, and population growth led to these cases. So ultimately, there were 88 cases in 2017, and then 212 more from 2017 to 2021, a total of 653 cases in Nigeria that were either confirmed or suspected since 2017. Now, how about the current outbreak? So this was initially found in England, in the UK. The first early case did have travel links to Nigeria. However, subsequently, multiple other cases did not have travel links. And quickly, cases were identified throughout Europe, as well as North and South America, and some in Asia. And they determined that this was from the West African clade of monkeypox. The first case in the US was identified in Massachusetts on May 17th. Since then, there have been 52,570 confirmed cases worldwide. And in the United States, there have been 1,962 cases. And in Illinois, there have been 1,087 cases in Illinois, specifically in DuPage County, 19. And I'm glad that this was the same number that you had in your slide, Dr. Chauk. So a little bit about the spread. How do you get monkeypox? So it is really primarily spread through direct skin-to-skin contact with infectious lesions or body fluids. It can be spread by respiratory secretions, but that takes a lot of exposure. It's prolonged face-to-face contact and typically in households. And it can spread during intimate contact between people, including during sex, kissing, cuddling, or touching parts of the body with monkeypox lesions. Now, monkeypox can be spread from the onset of symptoms until the rash has healed, all scabs have fallen off, and there is a fresh layer of skin that has formed. A little bit about the symptoms of monkeypox. So after exposure, it takes another 5 to 13 days to develop symptoms, on average about a week. In some cases, it can be up to 3 weeks. It can start with a prodrome before you get the rash. And these symptoms include fever, malaise, headache, muscle aches, swollen lymph nodes. When that prodrome occurs, the rash does develop within 1 to 4 days. Now, what does the rash look like? I'm going to show you pictures later, but I'm just going to give you some medical terms. So it starts as macules. These are red spots, followed by vesicles, which are fluid-filled blisters, followed by pustules, which are pus-filled blisters, and then they become deep-seated and umbilicated and then scab over. The whole thing can last 2 to 4 weeks. Now, this is really important. The recent cases have been atypical, with the lesions occurring in the genitals and around the anus, and often without the prodrome, without the subjective fever during the prodromal episode. So some people are getting no fever, or sometimes they get the fever after the rash starts. Now, this is important for clinicians to understand that the recent cases may be confused with other sexually transmitted diseases and other infections, such as chickenpox, molluscum contagiosum, syphilis, herpes. So here are some pictures. On the left, you see a vesicle. That's a fluid-filled blister. In the middle, you see a pustule. Kind of has that white appearance, looks like pus. And on the far right, you see the umbilicated lesion with the center there. And then in the bottom row, you see kind of the scabbing and the crusting over. And then finally on the right, you see with the skin peeling off. This is the late end stage of it. And these are some more pictures. This is a hand with the macules or red spots. And then on the right, this is another vesicle. This picture shows a pustule. And then these are other lesions on the back. So a little bit more about this. In MMWR, a case series was reviewed looking at the symptoms in this outbreak. So they looked at 2,981 cases from May until July 22nd. Nearly everyone was a male, 99% were men, 94% reported recent male-to-male sexual or close intimate contact, and 42% did not have the typical prodrome, did not have a fever before the lesion started. 46% reported one or more genital lesions during the illness, and 41% had HIV infection. Now, I'll have to look back to see if this includes everyone or just those that were tested. I'm not sure about that. And it does say here that widespread community transmission of monkeypox has disproportionately affected gay, bisexual, and other men who have sex with men, and racial and ethnic minority groups. A couple things to keep in mind, compared to historical reports, the current cases are less likely to have the fever prodrome, but more likely to have genital involvement. Okay, so for what are the symptoms and what should physicians be aware of, or what should you be aware of when you see your physician? So monkeypox should be suspected when someone has the characteristic rash or epidemiological criteria. So anytime we see the deep-seated and well-circumcised lesions with a central umbilication, like I showed you the picture, and if the lesions progress over the specific stages we talked about, the macules, papules, vesicles, pustules, and scabs. And then keeping in mind for physicians that these can be confused with other infections, and that just because someone has another infection doesn't mean they don't have monkeypox, and the vice versa, just because they have monkeypox doesn't mean they don't have another infection. And then also, who is highest risk to get monkeypox? So you have the symptoms, but are you in a high risk group? So if within 21 days of illness, you have had contact with a person with similar appearing rash or who have received a diagnosis of monkeypox, or if you've had close or intimate contact with individuals in a social network experiencing monkeypox activity that includes men who have sex with men, etc. And then finally, if it's more of a traditional exposure, like travel outside the US to an area of confirmed monkeypox outbreak, or if you have had contact with a dead or wild and exotic pet that is from Africa. Okay, so this is about testing, and this is more for healthcare, for the healthcare people, but just so you know, in order to be tested for monkeypox, it has to be done on skin lesions. There's no blood test for monkeypox. If you have a fever but you don't have skin lesions, there's no testing. It has to be on skin lesions. So I won't go through all the detail here, but I will hold this slide up so anyone who's interested can look at it later. I will say that in the past, physicians did have to clear the testing with the health department, but that's only if the testing goes to IDPH. If it goes to a commercial lab, they don't need to clear that, but they still need to report it to the health department as a suspected case. Okay, now I'm going to talk about treatment. So the medication, otherwise known as TPOXX or tecovirimat, and this was actually FDA approved for the treatment of smallpox. We actually have a smallpox medication around just in case there's a bioterrorism event and we have a smallpox outbreak. But as it turns out, this is also effective for a monkeypox. But it doesn't have FDA approval for that reason. So in order to get the drug, we have to go through the CDC. The CDC holds what's called a non-research expanded access of investigational new drug, or IND. So I think the way this works is the county health department holds the drug. If a physician needs the drug, there's a process where they reach out to the health department and apply for the IND through the CDC. So who gets tecovirimat? So it's actually approved for monkeypox, anyone with severe disease, anyone with who's at risk for severe disease. So someone who has an immunocompromised condition such as advanced HIV, cancer, or on medications that suppress the immune system. Children younger than 8 are at high risk for severe disease, so they can get treated. Anyone who's pregnant or breastfeeding. And then people with chronic skin conditions like atopic dermatitis, exfoliative skin conditions, or if the monkeypox shows up at a critical area of the body where there may be a high consequence of lesions, then the medication can also be approved. So now I'm going to get into prevention. So we know that men who have sex with men make up the majority of cases in the current monkeypox outbreak. However, be aware that anyone, regardless of sexual orientation or gender identity, who has been in close personal contact with someone who has monkeypox is at risk. On the next slide, I'm going to show you some of the prevention strategies, and just keep in mind this is has some adult content, so just be mindful of that. So firstly, Jynneos vaccine is recommended for individuals at high risk of exposure to monkeypox. So what should you do prior to getting vaccinated? So you're still at risk. The benefit of the vaccine is not until you get the booster dose. So from before getting vaccinated until 2 weeks after the booster dose. So during that time, it is recommended to avoid high-risk behaviors. Avoid skin-to-skin contact, especially to areas where there are lesions. Partners should be aware and communicate with each other about any symptoms, any unexplained rash or lesions in the mouth, genitals, or anus. Limit the number of sex partners. Seek immediate evaluation by a healthcare provider if you experience any symptoms, and notify your partners as such. And please especially avoid touching any rash, sharing any towels, and personal items when sick. Now, this is not a sexually transmitted disease, so condoms may not prevent this infection. Condoms will only prevent exposure to that area of skin that is covered. So you consider wearing gloves, increasing clothing, consider virtual options, and just keeping a distance. And then on the next slide, I'm going to talk a little bit more about the vaccines, a little bit more details. So the Jynneos vaccine was approved for the prevention of smallpox and monkeypox. There's another vaccine called ACAM 2000. This is actually approved for smallpox, but they're different. The Jynneos is a non-replicative virus, and the ACAM is a replicative competent virus. Now, there hasn't been any real-world effectiveness studies because it hasn't been tested on people with monkeypox, and we haven't had smallpox to use it. So it is recommended that vaccinated individuals should still continue to take steps to protect themselves from infection, even if they're vaccinated. So ACAM 2000 is a replicative competent virus. It's called the Vaccinia virus. This causes a localized virus infection in the skin and then spreads to the lymph nodes. We know that 95% of people who get this will develop neutralizing antibodies. There is a national stockpile which is intended to be mobilized should there be a smallpox outbreak through a bioterrorism event. So this can be used in a mass vaccination effort. So smallpox is a deadly disease. The mortality can be anywhere up to 20%. So this vaccine has a lot of side effects, but when you're dealing with a disease like smallpox, it makes sense to use this. However, it may not be appropriate for the monkeypox outbreak, given that the scale of vaccine needed can be met with Jynneos, and also there's significant proportion of people who have HIV and may be immunocompromised and can't get this vaccine. Okay, so the Jynneos vaccine, it's live, but it's not replicating. So it can enter cells, but it doesn't make copies of itself. So therefore, it's safe to give to people who are immune compromised. So it is a 2-dose series given 28 days apart. After the second dose, the antibody level was significantly higher than after the second dose of the ACAM 2000. So it works as good or better, potentially. Now, the only clinical studies are in animals, and in infected non-human primates, the vaccine protected them. 80 to 100% of the Jynneos vaccine animals survive compared to only 0 to 40% of control animals. So we know it works in primates. So that's what we have. So about the administration. So now it is a subcutaneous administration, so it goes in the arm under the skin. There's an alternative administration, intradermal. I'm going to talk about that in a little bit. Because of the supply issues, there was a need to get more out. And they went back to a study from 2015 that showed that a 2-dose series given intradermally provides similar immune response as subcutaneously, but you only give 1/5 of the dose. So now if we do this, we have 5 times as much vaccine to use. Now, I'm going to show you a quick video of how this looks. Let's see if I can get this up. You know what? I may not. Oh, yeah, here it goes. I'm trying to get out of this so I can get back to my PowerPoint. Let's see, I don't want to close. I'm scared if I close this, I might lose the whole thing. Oh, wait a minute. Oh, shoot. I'm just going to stop my share for a second here. Oh, boy.
Dr. Pinsky, while you're doing your problem solving, I want to
Can you mute?
note,
All right.
are you okay there? I do want to note to folks that we're behind the schedule that we had put out, and I apologize to all of you that we won't be able to get the same amount of things done in the same time period. And it looks like we will lose Dr. Mitch at 6 o'clock. Dr. Mitch, whatever you have to share with us, we commit that we'll get out to folks after the meeting. And thank you very much for your willingness to come and be with us in the event that we don't get to you.
All right, so I'm back. Let me get back to the last slide that I had. Okay. Okay, so the vaccination actually will be protective if it's given within 4 days of a high-risk exposure. And even if it's given after 4 days, up to 2 weeks, it may prevent severe infection. The vaccine is recommended in high-risk groups, and Dr. Chow went through what those high-risk groups are. Gay, bisexual, transgender, or sexually active with multiple anonymous sexual partners. And the vaccine can be requested by healthcare providers from local health departments. Individuals can go to vaccination sites through local health departments and multiple partners in Chicago as well. So I'm providing the number here for the DuPage County Health Department if to schedule the vaccine, as well as I'll go to the next slide. This is a event at the Neighbor Pride Fest. They're holding a vaccine clinic. There's a number at the bottom, 630-682-7400 to schedule that. And then also the vaccine will be available in City of Chicago, Cook County, and other counties. I've given the links to the City of Chicago, and they are offering it to anyone who's had close contact with anyone who's had monkeypox, and then also to any sexually active gay, bisexual, or other man who has sex with men, that they can also get the monkeypox vaccine. There's a link there. And then below, there's a link to this suburban Cook County. City of Chicago does say they do offer it to people who live in Illinois, not necessarily in the city. So you don't have to live in Chicago to get it there. This next slide shows the clinics in Chicago that offer it. Here are some phone numbers to those clinics. So I'll just leave it there.
All right. Well, thank you, Dr. Pinsky, for the very informative presentation. I actually really like that you went through the history of monkeypox at the beginning of the presentation.
Yeah.
So we do have a few questions for you. The first would be, are you okay with us sharing your PowerPoint? It was so informative and you had all the information centralized in one
Absolutely.
location.
Feel free, share it, share away.
Perfect. And our next question is, has the monkeypox virus been assigned a new name by the World Health Organization or the CDC, as the Wuhan virus or China virus was later identified as COVID-19 or coronavirus?
Yeah, that is the name, and it's a little bit of a misnomer because it didn't originate from monkeys. That was just where it was first identified.
Yeah, and I can also chime in here with this question as well. In 1958, when it was termed monkeypox, they didn't really have best practices for naming. So I know on August 8th, they had an expert panel that convened to kind of start and expedite the process for naming. And I know the Central African strand is considered Clade 1, and then the West African strand is Clade 2. So we're still waiting for a name from that expert panel.
I think also that they're accepting nominations on a website.
Yes.
I can try to put the link in if folks have a recommendation of a name that they would propose.
Yes, they are accepting nominations. And our next question is, when it comes to language for messaging, when it comes to public communication and messaging efforts, learning our lessons from the COVID pandemic that led to Asian hate, how can we provide accurate and effective messaging without placing blame on the community that it's mostly impacting, but also the community of origin? Do you have any suggestions for that, Dr. Pinsky?
Oh, I didn't realize that question was for me. Yeah, I think we have to, kind of understand that this is not a disease that's strictly, it's not sexually transmitted. It's just affecting that population because that's where it's being transmitted right now. But it could certainly get into other settings. It could get into, I know anyone has close contact. I mean, I'm thinking about things like high school wrestling team. If we get monkeypox there, it would spread there. It's just that right now that's where it's spreading, but it doesn't. Anyone can be affected. So I think it's very important to message that.
I find my
Great.
add to that. I think what we're doing today, educating people, making them aware of the origin of this disease, what the treatment is, and getting out in front of it. We didn't do that with SARS-CoV-2, and we allowed a lot of disinformation to just saturate the public airways. So this is a step in not allowing those, what would we call it? Those that is the association with something very, very negative with a disease. And I know from a conference I attended a couple of weeks ago, there is, I guess until there's an official name change, there seems to be oh gosh, I took something back at it. There seems to be a directive that we start referring to it as Mpox to alleviate some of the stigma from building. And almost everything I'm getting now regarding human monkeypox, they're referring to it as Mpox.
And one final question for you, Dr. Pinsky, and this is in regards to data and monitoring. Are there any plans for when that data is going to be released on the monitoring the vaccination and treatment by race and ethnicity so that we can identify other vulnerable groups?
Yes. So all I can say is that will be studied in terms of the effectiveness of the vaccine to prevent that, as well as the effectiveness of the drug treatment, tecovirimat. I know there's an ongoing clinical trial on the tecovirimat. I don't know about a placebo-controlled trial for vaccination because there's ethical issues around that. I don't think it'd be ethical to have a placebo group, but they can still look at and do comparisons anyway in real world and get what's called real world evidence of effectiveness.
All right, well, those are all the questions. Thank you again for your presentation, and I'll turn it back over to the host.
And I guess that would be me. So after the next portion of our town hall is going to focus on the emotional and psychological impact of MPX in our community. Because of the people that it's happening most to, our community already faces a lot of mental health challenges. At this time, we'd like to welcome Danica Macmillan and Allison Mitch. Allison is a physical therapist and sexuality counselor with a passion and talent for assisting clients in navigating their sexual well-being, including queer identified folk and people with a disability. Danica is a psychotherapist with Vaccination Health Systems, and she is a licensed clinical social worker with experience in healthcare, social services, crisis intervention, and case management. I'd like to add to that, Danica has much experience with the LGBTQ community and people of color. So welcome both of you. And who wants to go first?
Okay. Well, I was basically going to talk about how we are kind of at the brink of COVID and how that has affected much of what we are doing right now, as far as the emotional exhaustion that we've had from, the constant threats of what's coming out next. There has been memes about, the next virus, the virus of the month or the threat of the month. And, the fact that monkeypox is out now, and I know it's more so recently in this year in May, the messaging that has been put out is more so affecting people in the LGBTQ community. And so there are a lot of people who are not actually paying attention to the threat of this disease. So, one of the things that I always go back to being a therapist is, with all of the stressors of diseases and threats, mental health is also something that should be protected as well as physical health. And so, of course, my advice would be to, learn as much information as we can, as well as, seek counseling or therapy or even medication to help during this process. You can go, Allison.
Thank you. And thank you, Andy, for inviting me to participate in this panel. When Andy asked, exercise is my favorite modality as a physical therapist, and it is incredibly healing. It's preventative. It's even considered a vital sign by some individuals. It's that critical to our health. And many of us are familiar with the physical benefits, but there are mental health benefits too, which may be applicable to monkeypox. The problem is that there's not much information in terms of monkeypox and exercise. So I had to, when I was doing research for this panel, I'm like, oh, I don't actually know what exercise benefits there are for monkeypox. I have to generalize because there's not really anything out there, but lucky for us or not, with COVID-19, we do have some more information in terms of better resources for individuals that want information on exercise during isolation, for instance, or how to socially distance but still get your exercise needs met. So just to generalize from what is out there, considering that there isn't anything specific on monkeypox at this time, things that individuals want to consider are, when is it safe to exercise? So that would be things like when you don't have a fever and when you aren't exhausted. And so we are considering doing these exercises away from people following those precautions where you are isolating and socially distanced and that kind of thing. But you want to make sure that your body is healthy enough for exercise. So things like fever, you're going to already be dehydrated, so you don't want to add that to your system. And then exhaustion, you need to rest. So if you are just healing from scabs, maintaining your distance, keeping your surfaces clean, not sharing your towels, but you are safe to exercise, particularly for low and moderate intensity. Once you start doing high intensity, that is an additional stress to your immune system, and you are immunocompromising yourself essentially. For example, there's research done where after a marathon, for instance, a really high prolonged bout of exercise, those individuals are sick afterwards. Oftentimes you are putting yourself in an immune compromised state. So just be mindful of the fact that if you or your clients have monkeypox, to offer up the suggestion that low to moderate intensity exercise is probably their best bet. Exercise has amazing benefits for mental health, including things like improving quality of life, improving sleep, reducing depression, reducing anxiety, promoting pro-social behaviors like empathy, compassion, those kinds of things. So if we can keep individuals exercising while they are recovering from that, that is great. And then I did share some information in terms of, in the chat bar, in terms of how to avoid or prevent monkeypox spread during gyms, for instance. So if you are fearful, but you want to still continue going to your gym, you don't have monkeypox, wearing things like longer sleeves, pants, cleaning equipment before and after you utilize things should help. As the physicians have mentioned earlier, the doctors that presented earlier, that it's a lower risk to contract it through respiratory. It's usually direct contact. So just cleaning those surfaces, not sharing towels, and wearing long sleeves and long pants. And with that, I don't know if there are any questions, but I'll pause here for just a moment on the questions because I remembered I didn't share resources with you verbally. So checking out the American College of Sports Medicine and the COVID-19 link on their webpage provides a lot of information in terms of exercise while socially distancing or isolating yourself. Things like YouTube videos, on-demand exercise streaming, walking outside, getting, depending on your financial situation, there is exercise equipment as cheap as bands to as expensive as Pelotons or treadmills. So there are a variety of ways that you can meet this need for exercise for your body while also being mindful of your budget too. So thank you so much.
And with that, do we have any questions in the chat?
It doesn't appear that there are any questions at this time.
Okay, great. Thank you very much, Danica and Allison. I'm just going to take a minute now to reemphasize what we're going to have available at Naples Pride Fest. They'll be dropping into the chat a link for a 1-minute evaluation, and we ask for your help to know how we can improve on this kind of educational event. Please click on this link and invest a minute to help us. Thank you so much. On behalf of Naples Pride and the Health Equity and Access Response Team, I want to say thank you from the bottom of my heart to Dr. Chu, to Dr. Lipinski, to Ms. Macmillan, and to Dr. Mitch for your preparation, information, and engagement and question and answers. Thank you for your high involvement in the community. Always much, much love to both Danica and Allison, as I know them personally outside of this. Dr. Pinsky, thank you for taking your time. I know how important family time is in the evening like this. We really, really, really appreciate your efforts. And I think Dr. Chu has already left, but she has my deepest regard as well.
Thank you for having me. This was a really enjoyable and pleasurable. Thank you.
Thank you. And thank all of you for investing your time to learn information that you can share with your neighbors to keep our community safe and healthy. And we are adjourned. Come by and see us with the County Health Department at Naples Pride Fest on Saturday at Naples Settlement from noon until 10 p.m.
Hope for a great event. David or Becky, would it be possible for us to share a link to the presentation in addition to the PowerPoint, the recording, to folks that registered for this? And that way they could share that with others that might be interested in hearing the remarks of the speakers as well. Thank you guys again so much.
Thank you.
Have a great night all and a great
Thanks all.
weekend.
Thank you so much.
Good night.
Good
Thank
night.
you.